work with each other. It is extremely confusing. There are a lot of interconnectivity that needs to happen for the patient to be as smooth. Even if you go to the basic example, the registration is a different system. It could be called a patient registration system. Then doctors will be using something called an electronic system. The patient will be able to see the electronic medical records, the clinical records, the blood investigation is done by a laboratory information system. The radiology will have its own radiology system. And pharmacy will have its own system. When we talk about payment, we can have an RCM product. You are looking at 1, 2, 3, 4, 5, 6 different systems for a typical outpatient journey. Now, if the journey has to be so smooth for a patient, there is a need for all of these systems to talk with each other. What will end up happening? It will end up that the patient is not able to see the electronic medical records. The patient is carrying papers from one place to another place. This is what we see in a typical scenario in India. Once systems are implemented, he basically just walks from one place to another place. Just all he requires is his medical record number. So this is the need of the requirement of multiple systems within a hospital, talking to each other. Now, there is one more need, that why external systems? Would we have to talk? Why would that be a need for external systems to talk with each other? Is this visible now beyond the hospital screen? Yeah, it is visible. Okay. So let us talk about the 3 Ps. Okay. So the 3 Ps are within healthcare. All of you know is patients, providers, and as well as payers. What is the relationship between these 3 people? Patients are consumers. Consumers of what? Consumers of healthcare services. So in a typical Indian scenario, what happens? A patient consumes the healthcare services and makes a direct payment. So that is the most simplistic way of thinking. But as time has progressed, even within India we have a lot of insurance that is coming in, especially in case of an inpatient scenario. And in some instances for daycare procedures too. But in the United States, 95% of all healthcare transactions happens only through some kind of insurance program. That insurance program could be either run by government or it could be run by private companies. If it has been run by the government, what happens? Patients are also nothing but the population. They pay taxes or premiums. If the pairs are private insurance or pseudo-private insurance companies, they have to pay something called as premiums. In return, what do they get? They get an insurance coverage. When a patient takes services from providers, what these providers are required to do? They are required to send claims and bills, and they are going to receive payments. The providers and payers are heavily regulated by the government, by the law of the land. So the payers and providers are required to submit a lot of information. And there is an information flow that happens between providers and as well as payers. So whenever there is information that needs to be transmitted from one player to another player or from one actor to another actor, there is a need for information transmission. So that is nothing but healthcare interoperability. Is my slide visible again? Yeah, it's visible, Varun. Now this is an actual image taken from the ABDM website. Now, if you look at the players who are going to work with each other, include healthcare professionals. I'm going to start from the top right, one which starts with providers. Providers, which include hospitals, labs, pharmacies, wellness centers, allied private entities like third-party associates and insurance companies. Healthcare tech companies. Healthcare professionals, which includes doctors of modern medicine, Ayurveda, Unani yoga, Siddha, homeopath. Other practitioners which could include, like chiropractors, or people who are practicing Chinese medicine, acupuncture, acupressure, so on and so forth. Non-for-profit organizations. Development of partners, NGOs, associations. Then you are going to have regulators coming in. Then the policymakers of state governments and central governments. And amongst the middle is the citizen and patients. The whole idea is that to make all these people work with each other electronically. It's the fundamental idea of Aishwarya Bharat Digital Health Mission. So it is going to be in the next 10 years healthcare IT interoperability is going to boom a lot. So this is one example within India. So, similarly to this, you have something called as an ACO. An ACO in United States is basically ACO stands for Account Care Organizations. What used to happen earlier is that paper service was the mechanism how these hospitals would operate. So whenever a claim is sent for the claim, the reimbursement would happen. And this reimbursement would. It has complicated rules, so on and so forth, and that's the reason why medical quarters are there, and so on and so forth. But what an ACO is? It's called an account care organization, where a bunch of hospitals come together. And these hospitals are given X amount of money. And they are given a Y amount of population to be taken care of. So end of the year, if they save money, it is distributed within the ACO network itself. So, rather than just using a paper, use what happened. Is that okay? Since the ACOs wanted to save money, the population health management as a system came into being. So what is population health management solution? It is a solution where all the EMRs, the idea is, various EMRs used by different hospitals. It could be Epic Cerner, it could be Sunrise, all scripts, Meditech, whatever you say. All this information should flow into one single solution called as Population Health Management Solution, and from that solution, continuum of care is provided. And also from that there are various other risk analysis is done. Whoever are patients at risk, even before they consume more and more money within the ACO, they are treated. Okay, for example, diabetic patients. Diabetic patients are have more risk than a non-diabetic patient. So just I will give you a very simple example. So risk management, continuum of care, one thing, and also there are various. There are various statistical analysis that is done, which is required as part of ACO submissions. All this is done through a population health management. But for a population health management system to work, it is essential that each of these electronic medical records communicate with the population health management system in a standard way. So I have given you 3 different examples, one where it was just one single hospital. The second one, it was a hospital talking to 2 or 3 entities. And the next one is something much more beyond, where it is a complete ecosystem itself. So by now you understand as to what are the various kinds of interoperability that is required.